wanted to welcome everyone to Let's Talk Dental. This is a BIOLASE webinar series, and we're excited to welcome Dr. Praveen Arany as our speaker. The lecture this evening is titled Introduction to Photobiomodulation Therapy, What, Why, When? In this lecture, Dr. Arany will be exploring the role of photobiomodulation as a non-surgical and non-thermal application of lasers to alleviate pain or inflammation, modulate immune responses, and promote tissue healing and regeneration. As always, we are hosting tonight's webinar on the Zoom platform and welcome your questions during the lecture in the Q&A feature in the lower toolbar of your Zoom screen there. We'll wrap up tonight's session with several minutes to address audience questions with Dr. Arany, so feel free to post your questions during the lecture. Dr. Arany and I were just chatting before we started the webinar, and he's purposefully set up his lecture this evening to allow for quite a few questions. So again, we have the chat feature in Zoom, we have the Q&A feature. I'll be in the background monitoring that. So as he goes through his content and his lecture, anything you want to pick his brain about, please do. Just post those questions in there, and then I'll moderate those at the end of the lecture. At the conclusion of the lecture, I will provide information about BIOLASE education CE process, along with additional web resources you can access to continue your learning journey in laser dentistry, including information about our next webinar on September 19th, so here in a couple weeks. Tonight's webinar is being recorded. It will be posted to our webinar library in the coming days, and our education website is education.biolase.com. Dr. Arany is trained as a dentist and an oral pathologist. He completed a joint Ph.D. residency program at Harvard University as a Harvard Presidential Scholar. In 2015, he joined the Department of Oral Biology in the School of Dental Medicine at University of Buffalo, where he is today. He has over 125 scientific publications with several well-cited papers to his credit. His work has over 7,300 citations and is routinely featured in the mainstream media, including Fox News, CNN, MSNBC, Washington Post, BBC, Reuters, and MIT Technical Review, amongst others. Besides his academic interests in clinical translational research, Dr. Arany has co-founded 4 biotechnology companies to translate his lab research into real-world practical solutions to improve clinical care. His research is predominantly focused on the molecular mechanisms and clinical translation of low-dose light treatments. Work from his group has unraveled several molecular pathways that are enabling the safe and effective clinical translation of this innovative treatment. Dr. Arany, thank you so much for joining us this evening. I know this is a very hot topic in our industry, and I know our audience is pretty eager to learn more about it. So I will pass it over to you and let you take it away.
Thank you very much, Joe. Can you hear me clearly?
Yes.
Great, excellent. Thank you for that kind introduction. And thank you for the invitation to speak to this audience. So I purposefully titled this talk as Introduction to Photobiomodulation for the very reason that you mentioned, Joe, that there is a lot of interest, but also some misinformation around what this treatment is all about. So this is supposed to be a very simple and hopefully informative session about what this treatment is and also what it is not. So I titled it What, Why, and When, and I hope to walk through different kinds of light treatment before we get to photobiomodulation. And then when we are talking about photobiomodulation, I will focus almost exclusively on the major advance that has recently brought photobiomodulation into mainstream dentistry and medicine. So, and that is around supportive cancer care. So I'd like to spend some time on that. So let's get started. And as Joe mentioned, I love to take questions in any format. So if you're going to use the Q&A, please write up your queries or suggestions or your experiences, and I'm happy to try and address some of the information if I can. These are my disclosures. I work with various organizations and also have received various devices as research gifts that we use in many of our research. I will not be talking about any specific device today or endorsing any particular manufacturer. As you can see in the lower part of that slide, there are several organizations that are dedicated to bringing photobiomodulation to mainstream medicine. And as you can see here, the World Association, the North American, and various optical societies, including SPIE and formerly OSA, now called Optica. So all of these organizations are trying to highlight where photobiomodulation specifically is capable of adding to clinical medicine and dentistry. So I'll talk about several of those applications. So let's get started. I should have mentioned that the QR codes that you saw on the very first slide was both my LinkedIn profile as well as all the slides that I'm presenting today. And you'll keep seeing this QR code pop up in the corners or in one of the four corners. And feel free to download these slides and use them as you will. I find that because there are various terminologies that I will be using, which are non-clinical, it gets a little complicated. So I find that sharing the slides is usually very helpful. So please feel free to download the entire PDF of the slides and use them for review or for however you like to use them. I like to start, I do a lot of teaching in lasers in dentistry, both to predoctoral and residents, as well as to various colleagues. So I find it relevant if I could put what we do on a daily basis as dentists into the context of where light or lasers could be helpful. So if you think about it, you can broadly categorize most of our clinical procedures into three large bins. One, where we are trying to remove a noxious or infected or damaged tissue, hard tissue or soft tissue, and try to replace it with either a prosthetic material or help it regrow or heal. The other scenario, which I think all of us encounter again on a daily basis, is we are trying to disinfect tissues and create a suitable environment for tissue healing to occur. And in some cases, as shown in these images here, we are trying to boost the tissue healing response in the patient. So three large categories broadly where we are spending a lot of time on our daily basis in our clinics today. As I do a lot of teaching to predoctoral students, I like to show this particular slide where if I give you a nice sharp rotary instrument and ask you if you're going to remove calculus with it, or give you a nice curette and ask you if could you remove caries with it, most of the audience will probably say, no, we would not do that. Because even though these tools are capable of getting to the endpoint, they will probably cause lots of damage and not be used in a particular safe manner, right? So you would probably not do these kind of procedures with these instruments. So the purpose of this particular seminar today is to highlight how light can be used in various ways, and understanding the precise clinical application will help you choose how to use a laser. Most of us think of lasers as a cutting tool, but that is just one of its many functions. If you think about light, and if you have done any kind of laser training, you know that all of us like to start with, light has this unique physical property that it has both wave-like and particle-like properties. More importantly, in every known universal scale, whether it is the distance between stars in light years or the fundamental force holding subatomic particles together, electromagnetic radiation or light is always present. So to put this in context, we are only studying a very small part of our universal scale in terms of how light affects biomolecules, such as nucleic acids, amino acids, lipids, and carbs, or how that effect can be elevated and integrated by cells and tissues or organs. And ultimately, we are looking for a therapeutic outcome in our patients, right? So the entire organism. So we are only studying one small part of how light interacts with living matter. And to put that in context, we have many, many different kinds of lasers. And all of you are familiar with both the diode lasers and the all-tissue lasers, which largely belong to either the CO2, the erbium chromiums, and the erbium YAG. So just a picture to show you different kinds of lasers. As I mentioned, we normally think about lasers, and when we give these talks, most people are very familiar with laser as a surgical tool. So the first question that we usually get is, can a laser be more than a surgical tool? And for that, we draw an analogy between something that all of us nowadays carry in our pockets, smartphones, right? Smartphones can communicate in different protocols. They can communicate in voice, they can communicate via Wi-Fi, Bluetooth, or near field communication, right? So you can use it as a credit card for payments and for identity. So a single tool and its ability to communicate in different protocols enables different functions. And I hope the biggest message that you take back today from this seminar is that the laser is one such clinical tool. If you understand the biological context and the clinical outcome you want to achieve, the laser can work in very different ways. So there are different approaches to using laser energy. And for that, and this is probably the most important slide for the evening, if you transfer light energy very quickly into the biological tissue, you end up disrupting it or ablating it. And this is the physical principle of how surgical lasers work, either for hard tissue ablation or for soft tissue ablation. We all know that there is also photocoagulation around the area that you're cutting soft tissue. And this is also inherent to the heat mechanism that is seen with surgical lasers. If you can remove biological tissue, oral, hard tissue, and soft tissue, you can definitely remove biofilms, right? So you can do thermal disinfection, and we tend to refer to the term photothermal disinfection or photothermal therapy to refer to surgical removal of biofilms. In contrast to the surgical application, I hope you have heard of the non-surgical approaches where you're using lower amounts of laser energy. Hopefully you can see my arrow here now. The lower amounts of energy, and you can accomplish two very distinct kinds of laser or light treatments. One is photodynamic therapy, and the other is photobiomodulation. So as I go around, talking about photobiomodulation, I find that there is a lot of confusion between surgical photothermal therapy and photodynamic therapy with what photobiomodulation can do. So to put this in context, I would like to very briefly introduce both the surgical aspect as well as the photodynamic aspect, and then spend the bulk of our time together on photobiomodulation. So if I may, let's get started with the surgical aspect. We all know that surgical lasers are amazing for incisions, excisions, curettage, and I mentioned photothermal disinfection. The idea here is that you want to remove tissues or damaged or infected tissues, and you're going to use heat or thermal energy to achieve that end goal. If you think about lasers, and we just very briefly mentioned, I showed you a picture of different kinds of lasers. We largely think of lasers as either diode lasers or all tissue lasers. And again, some images to show you the different kinds of lasers. I'm sure many of you have many of these in your practice. And then again, what I don't have on the slide is that we also classify lasers based on their source, whether they are gas lasers or diode lasers. And we also classify them based on their power levels. We call them class 3Bs or class 4s, which are largely the lasers we use in clinical dentistry. But as we are teaching more and more of surgical lasers and non-surgical laser treatments, we find that another distinction as we are training the next generation of laser dentists is the manner in which we use them. So most diode lasers, as you know, are in contact. You'll have to use them in contact to do surgical cutting. While many of the other lasers, for example, the CO2, you use it in a non-contact mode. And we find that that is a new set of non-tactile skill that we have to impart in our trainees. So we have started using this contact and non-contact laser just for training purposes. As you think about surgical lasers, and again, this audience, I think, is very familiar with the use of surgical lasers. And this is just a simple case showing you the advantages of using surgical lasers instead of a blade and curette. And you know that you're photocoagulating as you cut. So you're working in a bloodless field. You have minimum scarring. And you also notice that the patient is not only more comfortable during and after the procedure, but even during follow-up. So they will give you a history of minimal analgesic use after the laser procedure compared to a blade or a curette. There is minimum inflammation, And you can, almost every dentist that you talk to who uses lasers will tell you that wherever you place your cut, the margin does not retract. And that is largely because there is very little inflammation in those soft tissues. So the healing is really pristine. So you can see the healing margin here, where we place the cut, it has not actually moved much. And this is great if you're thinking about other kind of aesthetic procedures such as smile design and various other surgical laser procedures. So high power lasers, just to summarize, are largely popular for soft tissue. And again, this particular audience is very familiar with hard tissues. And there is a growing recognition that you can do a lot more with your laser than you can do with your rotary tools. The advantage, and we try to highlight the fact that everyone knows about LASIK in the eye, right? So the precision that you can imagine to reshape the lens and improve vision can also be accomplished in oral soft tissue and hard tissue. So you can get precise size, depth and width of your cutting fields with a laser. We talked about the bloodless field and the improved healing. And usually they are very connected, because if you can see what you're doing with a laser during a cut, you tend to not go twice or thrice over that area and cause inadvertent tissue damage. So all of these are great advantages. Like every new technology, and I mentioned the non-tactile field, many of these lasers are infrared, so they are invisible, and they have specific safety concerns that have to be addressed both in a teaching and a clinical setting. So something that I think people are appreciating more and dealing with it more. I think it's not as scary as it used to be maybe even 5 to 10 years ago. And I think a great metric for success of acceptance of surgical laser comes from this recent American Dental Association technical report number 133 that several of our colleagues actually put together. It's a really, really good set of current state of the field, and I highly recommend looking at this publication to outline where the surgical laser field is currently. So hopefully this summary shows you what a surgical laser can do, and I want to emphasize surgical lasers is not photobiomodulation, right? So when we talk about photobiomodulation, we want to distinguish what the surgical laser can do from a non-surgical photobiomodulation procedure. So again, if you have any questions or comments about that, please put them in the chat in the Q&A feature, and I'd love to discuss that at the end. So moving on to the second part, there is again a lot of confusion about what is this other form of treatment which is not a surgical part. So the first non-surgical treatment I'd like to talk to you about is photodynamic therapy. Photodynamic therapy comes in two flavors. It is usually an anti-tumor, which dentists usually do not deal with. But antimicrobial photodynamic therapy is something that you're going to hear a lot more about, and I'll show you the clinical evidence for that. So the primary purpose of PDT, as it's called, is disinfection in case of antimicrobial, but the overall goal is to destroy its target. And it achieves this in a non-thermal manner. So you're not using heat, but you're using this chemical intermediate called reactive oxygen species, ROS. And again, one of the most popular ROS in the clinical dentistry is hydrogen peroxide, right? So all of us are very familiar with ROS, or hydrogen peroxide. So you're generating relatively high levels of ROS where you're shining light. And you can accomplish this by using two components, a dye and a source of light. And the light doesn't have to be a laser, it could be an LED. So photodynamic therapy actually is not a new treatment. This gentleman here, Neil Rydberg Finson, in the late 1800s was using this lens apparatus that you see in this image here, and he was purifying sunlight. He was purifying sunlight into blue and red, and he was able to treat very effectively lupus vulgaris, infections of the skin. This work was so pioneering for its time that he actually received one of the very first Nobel Prizes in medicine and physiology. So this is not a new treatment. It has been around for a very long time. So how does this treatment work? All of us have done this experiment. We have all gone out into the sunlight, taken a magnifying lens and tried to focus the sunlight and burn something, right? So this is how you should think about PDT. So you're using a chromophore, which is basically the same as your lens in that other image that I showed you. And this photosensitizer or chromophore can be a dye, or in more sophisticated, it could be a nanoparticle that can actually target different species. So when you have this particular dye and you shine light of the right wavelength, a matched wavelength, there is generation of these ROS species, such as hydroxyl radical superoxide. And because these dyes or nanoparticles are very intimately bound to the microorganisms, or in the case of tumors, tumor cells or blood vessels in the tumors, they will actually destroy its target selectively. So light in the other normal tissues does nothing, but light where there is a target that is painted with a dye or a chromophore or photosensitizer will selectively generate the ROS and destroy its target. So PDT is a non-surgical, non-thermal approach, which essentially ends with destruction of its target. And this treatment, I'll show you in a second, is something that clinical dentists should be paying a lot of attention to because of the growing evidence of its efficacy. If you wanted to do PDT, you could use a laser or you could use LED lights along with either a natural or a synthetic chromophore or a photosensitizer. So here are some examples of the light-based systems and some of the photosensitizers that are available. And I think most dentists are very familiar with methylene blue, which is actually not on this list. But that's a very common photosensitizer that is used in various PDT procedures in clinical dentistry. Now, as you are learning about new topics in clinical dentistry, we keep going back to where is the evidence. So the highest level of evidence from basic research and clinical studies is a systematic review and meta-analysis. So I will point to this paper that came out in JADA, a prestigious Journal of American Dental Association, in 2015. So that's almost 9 years ago, where they showed that adding PDT, photodynamic therapy, to routine scaling and root planing can provide moderate improvements in your clinical outcomes. So they were looking at clinical attachment levels, and they found that if you add PDT after scaling and root planing, you can actually get better attachment levels. And again, there are several procedures that have been used and modified to fit this kind of treatment regime. So I will emphasize you cannot skip SRP. You need to still do SRP. And again, there are several companies and protocols out there that are using lasers to do SRP, which are also quite effective. Now, the reason PDT works really well is that not only is your chromophore painting your target, which is then destroyed by light, light itself is capable of being completely diffused. You can think about complex or deep pockets or furcation areas where your instruments cannot go into every nook and cranny. So by using light, you can actually diffuse the amount of energy all through that area. And that is one of the major reasons we believe that you're seeing improved clinical outcomes when you add PDT to scaling and root planing. So this treatment, photodynamic therapy for antimicrobial management in periodontitis and periimplantitis, is at the highest level of evidence. And I urge you to look at this paper and the evidence that they have reviewed. They did 10 randomized clinical trials, and they've had over 300 patients, and the evidence was in favor of adding PDT to scaling and root planing. So before we start talking about photobiomodulation, I want to again emphasize that there is a lot of confusion in the field. So I find it's helpful to summarize that although PDT and photobiomodulation, PBM, that we'll talk about in a second, are both low-dose, non-thermal light techniques, the major distinction is how they are used. So PDT normally uses an exogenous dye. The amount of ROS, the reactive oxygen species that is being generated, is a lot higher. And most importantly, the ultimate outcome of PDT is that you're destroying your target. This is in contrast to what we are trying to do with photobiomodulation, which works with endogenous chromophores, generates low amounts of ROS, and can either stimulate or inhibit, modulate its target, but it does not destroy its target. So that is a major distinction between PBM and PDT. So hopefully this has put both the surgical lasers as well as non-surgical PDT in the context of what I really want to talk to you today, which is photobiomodulation therapy. And every time we talk about photobiomodulation therapy, most people make fun of us, saying that, people are not plants. How can you shine light on people and expect them to get better, right? We don't do photosynthesis. And we point to the fact that although light has not been, taught to us in clinical dentistry or medicine, light has an integral role in normal human physiology. If you look at sunlight and what it does to vitamin D metabolism in the skin, we all acknowledge that it has a key role in bone and teeth metabolism and maintenance. Your very ability to see the slides, your vision, is actually enabled by a protein, rhodopsin, in your eye. We don't have electronic sensors in our eye, so how are we interpreting physical light energy? And we know that there is actually a biological mechanism. We also know that light has a very important role in our circadian rhythm and our psychological states, right? Bright places are always good for your mood, and it elevates your feeling of happiness and satisfaction, while dark places tend to make you more gloomy. And we all know about circadian rhythms. So the day-night cycle has a major impact if you don't sleep well or are awake at late hours in the night. So all of these are great examples of how light has a key role in our physiology, in our normal physiology. So photobiomodulation can be thought of as using light in a therapeutic manner, right? And this treatment was first described when Dr. Andrea Mester, a Hungarian physician, was looking at doing dose escalation studies in his animal studies. And he found that when he made wounds on animals and turned the laser power down, he was seeing stimulation of the wound healing. And he used the term photostimulation to describe the acceleration of the healing response, as well as the growth of fur, the hair on the back of the mouse. It took, if you look at the literature, unfortunately, there are over 350 different terms to describe this treatment. And everything from cold laser treatments to low-level light treatment, LLLT, to infrared therapy or bright red light therapy have all been used. So in 2014, in a joint meeting between the North American and the World Association of Photobiomodulation in Arlington, Virginia, the group of global experts got together and agreed to use the term photobiomodulation, which is now a mesh term, a medical subject head term in PubMed. So all of us use PubMed to do searches, which is the database of the National Library of Medicine. So all of the literature, which encompasses more than 350 different terms, now is indexed under this term, photobiomodulation. The National Library of Medicine calls photobiomodulation as the use of a non-ionizing source of photonic energy that generates non-thermal therapeutic benefits. In our field of photobiomodulation, we like to use a larger definition where we talk about different sources of light, and we acknowledge that besides lasers, LEDs, as well as certain broadband light sources, are capable of producing photobiomodulatory response. We also talk about how this is a non-thermal process involving endogenous chromophores that elicits both photophysical and photochemical events at various biological scales. Most importantly, we like to use the term photobiomodulation because if you use the right protocol and the right device with the right settings, you can promote certain positive processes such as wound healing and tissue regeneration and a beneficial immune response. And if you use another protocol and another device setting, you can inhibit certain negative processes such as pain, inflammation, or an aberrant autoimmune response. So you can accomplish both. So you can modulate the biological response depending on how and where you use light in an appropriate manner. So photobiomodulation has gotten a lot of press in the recent times, and I'll show you some of the recent advances. And one of the biggest questions or concerns in the field that we often encounter is how is this thing working and why would we use photobiomodulation in a particular clinical context? So to simplify this, I'm going to show you a rather complicated slide in a second, But to simplify this, as the definition of photobiomodulation outlines, photobiomodulation can directly address pain, inflammation, immune response, and stimulate healing or tissue regeneration. And this is actually in the definition of what photobiomodulation does. At the cellular and the molecular level, and I apologize for the complexity of this slide, this outline actually shows you where we are with our current understanding of photobiomodulation and how it works. So broadly, we think of them in three major categories. So light can be absorbed by an enzyme within the mitochondria called cytochrome C oxidase. And when this enzyme absorbs light, its normal electron transport function, where it's increasing ATP and ROS inside the cell, can lead to therapeutic signaling. Another mechanism that is involved is light-sensitive transporters or receptors. And one of the major ones that many people are focusing on, including our group, is the pain receptor TRPV1. When light is absorbed by this molecule, it blocks conduction of the pain signal, very similar to local anesthesia. The third mechanism was described by my lab, where we showed that an extracellular growth factor, a growth factor that is present outside the cell, can be light activated, very similar to how rhodopsin can sense light. So there is a conformational change that activates this molecule. So in the field of photobiomodulation, we acknowledge that all of its various biological responses and thereby the clinical benefits can be attributed to one of the three major categories of mechanism. And we think of the mitochondrial mechanism as a performance mechanism. It's improving the fitness or resilience of the cells, while the transporter mechanism is more for the pain relief, analgesia or anesthesia. And then the growth factor activation is thought of as the regenerative or tissue healing response. So all of these are known, well demonstrated and published pathways. And as you can see, there is a lot of complexity here, but there are different mechanisms. And therefore, the same treatment in different contexts is capable of activating different therapeutic responses. This is just more data on the third mechanism, which was described by my lab. And again, I'm making all my slides available, so feel free to look at this carefully. This basically shows you that if you increase the amount of laser light, we are using an 810 nanometer laser diode in this case, you can see that as you increase the amount of light dose, you're increasing the amount of ROS, reactive oxygen species. And we're using this red dye here. And you can see that there is more red as you go towards the right, and you're increasing the laser dose. And just like I mentioned, rhodopsin and its conformational change, the growth factor that we have been working on, TGF-beta, has this kind of a closed conformation. And if you want to activate it, especially with light, you have to change the conformation and thereby activate signaling. So we have shown this both in vitro in biochemical studies, as well as in vivo in various mouse models. And I'll show you a little bit of data in the latter part of the talk. So now that we know photobiomodulation and we can distinguish it from surgical lasers as well as photodynamic therapy, where can we use photobiomodulation treatment? This is where I'm going to juggle a little bit and see if I can play a brief video. Let's see if I can play this video. So we find that showing scientific data is great, but showing news articles is even more impactful. And so people tend to believe news stories. So here's a very interesting news story that was done during COVID and got a lot of press from my colleague, Dr. Scott Sigman in Boston. So let's watch this video.
A doctor in our area says he may have found a new way to treat COVID-19 with the laser light targeted at the lungs.
Yeah, this is pretty fascinating stuff. The patient was skeptical at first, now, though, a true believer, and says he's breathing better because of it. Christy Lee explains how it works.
I forgot I was asthmatic because I've been so healthy all along.
But in mid-April, COVID-19 quickly reminded Patrick Romero.
My energy was just slowly seeping out of me.
He struggled to breathe until Dr. Scott Sigmund, an orthopedic surgeon with Lowell General Hospital, came to his bedside.
So he was in the hospital for about 10 days. He had been in the ICU and he was almost intubated, and then they brought him back to a monitored floor, and that's where we got to meet him.
Dr. Sigmund told him about his idea, using laser light therapy.
Because it worked so well on acute inflammation, and that's really what COVID is. It's really inflammation gone crazy, and so that was the concept of why we would try the laser for COVID.
Patrick signed on to be the first of 10 patients in Dr. Sigmund's clinical trial.
After about 3-4 minutes, I started breathing a little bit better.
He received 1 treatment a day for 4 days.
His chest x-ray improved dramatically. The lab markers that we look for inflammation improved dramatically as well.
Dr. Sigmund knows that his clinical trial was too small. That's why he hopes a large research hospital will take what he started with a laser and conduct a bigger study to test his theory.
He won me over.
Patrick feels lucky to be alive. After 4 months of recovery in physical therapy, he still struggles with stamina and strength.
But I'm on my way. It's a lot better. I've gotten a fighting chance.
Christy Lee, NBC 10, Boston.
All right. So in many of our photobiomodulation seminars, we show a lot of different clinical applications. And I think that is one of the reasons why it has remained a little bit more complicated than usual to show you all the different applications. So I'd like to start with this brief video. Can you see my PowerPoint? Can someone confirm that I've switched back?
Yes. Yes,
Okay.
sir. We are good to go now.
Great. So the juggling has worked. All right. So where can we use photobiomodulation in dentistry? And this is just a broad slide talking about various medical and clinical applications, including dental applications. And you will see that there are several chronic diseases well beyond dentistry. Nonetheless, I think we encounter many of these in our loved ones or sometimes our own selves. So you can see things like Parkinson's, Alzheimer's, concussion, as well as knee pain, arthritis, tendonitis. And you will see on the table on the right that there is a comprehensive list of various dental specialties that use photobiomodulation very effectively. I quickly took a peek at the chat and I saw that there was a question about orthodontic pain and accelerated tooth movement. So PBM, photobiomodulation or low-level light has been very effectively used in those scenarios. So I just showed you this study. It was done by Dr. Sigmund and his colleagues, and it is one of the most cited work in our field right now because of the potential impact on the inflammation of the cytokine storm. And you can see that the patient recovered wonderfully after the light treatment as an adjunct. He got standard of care, but the light treatment helped him do better. So photobiomodulation has gotten a lot of recent press around this particular application, which is oral mucositis as a consequence of oncotherapy, either radiation, chemotherapy combinations, or graft versus host disease. So again, the highest level of clinical evidence in terms of a systematic review and meta-analysis was performed by the Multinational Association of Supportive Care in Cancer and the International Society of Oral Oncology that showed from 35 placebo-controlled, multi-center, blinded human clinical trials that giving photobiomodulation before you receive chemo or radiation, or therapeutically if you have ulcers or mucositis in the mouth, is very effective in terms of mitigating this potent side effect. So MASC and ISO recommend the routine use of photobiomodulation even in cancer patients who are going to get chemoradiation or present to your clinic with mucositis in their mouth. If you want to look up the latest protocols, the World Association of Photobiomodulation in this third paper actually has recommendations on how to use photobiomodulation. So I'd like to switch gears a little bit here and show you some of the research evidence for why this treatment is getting so much attention. So here's a very simple experiment we do in our lab where we take oral keratinocytes, epithelial cells from the mouth, oral keratinocytes, and put them on a plastic dish. And then we scratch them with a plastic tip, creating a wound. This wound, if you watch over time, as you can see in this time lapse here, will actually close over time as the epithelial cells come together. If you do photobiomodulation treatment, and again, we're using a particular setting with a particular laser here, we find that this wound that we have created will close much more quickly. And that is largely because the cells are migrating faster and are turning over faster. So this is very clear evidence in a very controlled lab setting that light and light alone, we're not adding any growth factors or any other kind of dressing. So these cells will tend to proliferate and migrate much more quickly. And this gives us credence to what we are seeing clinically in our patients. The other thing we noticed is that when you look at these edges in the side of these wounds, we know that there has to be proliferation of the stem cells in that area. Otherwise, you would be left with gaps if the cells move forward and there is nothing filling it at the back end. So we looked at that using a very specific assay called colony forming units. And you can see in this black bars here that if you do photobiomodulation treatment, you can significantly increase the number of colonies, both in terms of size and number. So you're increasing not only the stem cells within the margins of the wounds, but you're also promoting their migration. And thus, we see this therapeutic effect or benefit in our patients. We have done similar experiments in mice models, where in this particular case, you can see that we have created third-degree burn wounds, so full-thickness burn wounds. And you can see that this is the normal healing response that occurs in these animals. And if you use photobiomodulation therapy, you can see that the wound has closed much more quickly. When you're doing experiments in the lab, we always ask ourselves, is this phenomenon real? And how do we prove it? So in this particular case, what we did is we created a mutant, a chimeric form of the growth factor, TGF-beta. And when we make this particular animal, we have actually made this mouse, you can see that there is no activation. This is the activation that you see with light. But if you do this experiment in the mutant mice, you don't see this activation. And as you would rightly predict, in these wounds, when you make full thickness burn wounds, you can see that the wound has not gotten better, proving to us that activation of this growth factor turns out to be a single amino acid is actually a potent way in which light is capable of stimulating healing. So this has been, this has again been published a few years ago. And many studies like this have led to recognition of photobiomodulation, both from scientific professional societies, such as the Multinational Association of Supportive Care in Cancer, International Society of Oral Oncology, the World and the North American Association of Photobiomodulation. But it has also gotten attention from the Food and Drug Administration, as well as the American Dental Association. So as you can see in these publications, very recent publication, photobiomodulation is now recognized as a discrete kind of light treatment. It is not PDT and it is not surgical laser. So this kind of treatment is distinctly different. If you wanted to do photobiomodulation, there are several surgical diode units that are available that have adapters or handpieces that can be fitted on. And these can be quite effectively used for photobiomodulation. However, if you want to do a larger number of patients, you should consider investing in a dedicated photobiomodulation unit. And I will point out that these units cannot be used for surgery. So these are dedicated PBM devices. If you're interested in learning more about the protocols, the World Association has published protocols both for extraoral, as you see in these images here, that the patient is being treated even before they get chemoradiation. So it's a huge practice builder, because every cancer patient for 6 to 8 weeks, unfortunately, will be getting chemoradiation, and they need to be getting this treatment 30 minutes to 2 hours before they get their infusion or are being subjected to radiation. There are also devices on the market that can be inserted inside the mouth. And again, there are limitations and pros and cons to doing it through both the techniques. So depending on your practice and whether you're treating pediatric patients or adult patients, and depending on their conditions, you can choose to do it either which ways. Again, just another busy slide, but I wanted to highlight that if you use photobiomodulation and you start generating heat, you will start negating your benefits. One of the biggest concerns with photobiomodulation has been its clinical consistency. And with all these studies that we have done, including this particular study, we have shown that if you go into the thermal regime, which is easier to do with a laser compared to an LED, you start inactivating various ROS scavengers, such as catalase, glutathione peroxidase. And if you increase the temperature between 42 to 45 degrees, you will start seeing a damage response, which is essentially going to negate your photobiomodulation therapy. So the other question we often get is that if you're going to do photobiomodulation for mucositis in head and neck cancer patients, would my cancer cells in the patient also proliferate or increase? And the answer is an unequivocal no, it does not happen. So this first study here is a basic science study. The last study is a basic science study in mice that were implanted with head and neck cancer cells and treated with light at different doses. The tumor did not increase in volume compared to its normal kinetic growth. The first two studies here are actually clinical studies, and they are largely from Brazil because they have been doing oral photobiomodulation for oral mucositis since 2011, and for almost all of their tertiary care cancer patients. And they did a retrospective analysis to see if any of their previous PBM-treated patients had more incidence of recurrences or new secondary tumors. And both these papers have shown very clearly that you do not increase the amount of tumor burden. In fact, there is evidence from our lab and many other labs that because the tumor cells are wired differently, they use the photobiomodulation energy and commit suicide. So they undergo a process called apoptosis or autophagy. There is also evidence that there is an improved immune surveillance mechanism that can get rid of the tumor. So this is, again, research, and there is some clinical support. But in terms of your concern, whether your cancer patient will actually get worse or get more tumors, the answer is unequivocally no. So there is no chance of increasing tumor burden. Finally, I'd like to end with this slide where there is an increasing number of wavelengths that are being available. And you will see that photobiomodulation, most people are using either red or infrared, 8-10 nanometer. But there is now evidence that if you use the right amount of energy, including 940, 980, 1064, or blue, green, and orange, right? There are newer wavelengths on the market now. If you adjust the amount of photon energy when you're doing the dose calculation, and we use the term photonic fluence or the Einstein, we can actually adjust the dose in a very precise manner and thereby get therapeutic benefits. So you will see that the new guidelines, especially from WALT, the World Association of Photobiomodulation, uses this terminology to actually allow usage of other wavelengths where there is less evidence. So hopefully you have seen that you can use light energy, lasers, in both surgical and non-surgical manner. And each approach has its role in your clinical management. So every technique has limitations and advantages. And understanding where to use which technique is going to be critical for effective patient management. Photobiomodulation is an innovative, non-invasive, non-pharmacological form of light therapy, and it has many, many different applications. I discussed only one of them. There are significant evidences for peri-implantitis, improved wound healing, as well as other applications, including aphthous ulcers, lichen planus, and TMD, temporomandibular disorders. So our increasing understanding of how this treatment works, including molecular mechanisms and clinical dosing paradigms, are enabling this treatment to be used more widely. Again, all my slides are available if you can scan that QR code. And I believe Joe mentioned that this will also be archived, so you can see this later. And with that, I would like all the people in my lab who have helped us do this work, all the funding support, various mentors and collaborators who have provided key reagents. This is my email, and that's my LinkedIn profile and some images of my lab. I'll turn it back to you.
It takes a village, right, Dr. Arany?
I'm sorry?
It takes a village, right? It takes a village.
All of that.
So
Yeah.
you great photos of your team there. Thank you so much for a wonderful, wonderful presentation. We had a couple comments just about how exceptional your research is and your presentation was. So we definitely appreciate you coming on board here and presenting out your research and this information. I know our audience really enjoyed it. I did want to hit just a couple of questions that were posted during your lecture. You mentioned, I know you stopped and mentioned the question or the answer to this question during the lecture, but I just wanted to reiterate this. Can low-level light be therapeutic for orthodontic pain? Do you mind just answering that again real quick?
Absolutely. So there is a lot of excitement on the use of lasers and photobiomodulation in orthodontics. And one of the major applications has been reducing the pain after mechanical activation. So all that literature that you see in terms of accelerated tooth movement actually focuses on the orthodontic pain that is initiated immediately after mechanical activation. The way this works, I mentioned those pain receptors that are light sensitive. So just like anesthesia can reversibly and transiently block conduction of pain signals, light is capable of doing that at the right wavelength, right color, and the right dose. As you know, if you use a surgical laser, you can cause significant damage. So you have to be careful when you're doing photobiomodulation to use the right dose, and that is able to effectively reduce pain.
Very good. Thank you for answering that again and going a little bit deeper there. You know, I'm reviewing some of the other questions, and there's I think a theme that I'm seeing, and that theme is related to like specific protocols that doctors use for PBM. Can you elaborate on any type of specific protocols that your lab has found with PBM?
Yeah, so unfortunately, one of the reputations of PBM in the clinic has been its inconsistency, right? A lot of people, we make the analogy of the point and shoot cameras. You buy those cheap cameras and you can take nice pictures on a vacation. Unfortunately, PBM is practiced that way. People just buy a light device, press some buttons and treat the patient and hope that they get better, right? So there is no diagnosis and there is no prescription, which is something that we have been emphasizing in the field. So you need to understand, laser is a tool, light is a tool. You need to understand what are you trying to accomplish. Are you trying to do disinfection? Are you trying to reduce pain? Are you trying to stimulate healing? And now we understand, because of all the molecular pathways, that each one of those protocols is different. We don't use the same setting. People have often used the term 3 joules per centimeter square is PBM. That is no longer the norm. So we know that we need to use different kinds of light devices, maybe different wavelengths. We also know that we have to either use CW or pulsing, and we need to do different dose levels to get pain relief, inflammatory relief, or stimulation of healing, and even stem cell differentiation. I didn't show that data. A lot of the research in my lab has focused on endogenous stem cells being recruited for healing responses. So I will leave you with one term. So think about using light with a diagnosis and a prescription, and then the protocols will start making sense. Light is universal. We just talked about how light is everywhere among the stars and everywhere on Earth. So if you use the right protocol, you should get the same therapeutic response, whether you're in US, Brazil, India, or Paris, right? You should get the same therapeutic response. The point is you must use a rationalized way of using this.
And there was a question, I know you reviewed this at the beginning of the lecture, but I think it's important to reiterate before we wrap up with the audience as far as the main difference between PBM and PDT. Can you summarize that again for our audience as we wrap up?
Yeah, so the term photodynamic therapy or photodynamic action should immediately bring the thought in your mind that I'm trying to destroy something, right? So PDT is meant to destroy its target, whether it's a tumor cell, whether it's a blood vessel supplying a tumor cell, or an infectious agent, any kind of microbe. Photobiomodulation will always modulate, either inhibit or stimulate, but it should not be destructive. And if you use the wrong PBM protocol, which unfortunately many people are doing, you will end up doing PDT, which can also be therapeutic, but that is not the goal of what you're trying to accomplish. So PBM is non-destructive, PDT is destructive. The rest of the nuances, whether the presence of a chromophore is present, how much energy, how much ROS, those are nuances. But the biological outcome should dictate what you're trying to do. Are you trying to destroy a biofilm, or are you trying to inhibit pain or stimulate healing? Those are completely different end goals.
I see. Thank you for summarizing that. And, I think I'll leave with, we've gotten quite a few questions about specific procedures. Anything from, can PBM be used for post-frenectomy follow-up? Can PBM be used, do you have any experience treating burning mouth syndrome, soft tissue graft? So, a lot of our audience members I can tell that they're thinking through specific cases that they may have lined up and thinking, can PBM help with this specific procedure? Instead of asking one by one these different procedures, any thoughts you want to share as we see our audience thinking through this before we wrap up about how they can use PBM in their practice as they look at their patient calendar and see how they can integrate it in?
So in one word, the good news is yes, it can be used for everything. Unfortunately, you have to understand what you want to accomplish with light or photobiomodulation in each one of those cases. If you're thinking about burning mouth syndrome and you're thinking about mitigating that pain, even trigeminal neuralgia, there is striking improvements in the ability of PBM to relieve clinical symptoms, right? However, or if you're trying to heal a graft or you're trying to, post-extraction, you want to treat paresthesia. So all of these are largely pain or inflammation or stimulating healing. And you have to understand that if you have a diagnosis like that, you have to understand what is my prescription, which is what wavelength, how much energy, how am I delivering it, how often should I deliver it? And when you start looking at protocols, if you pay attention to that, you will quickly realize that it can treat a very large number of different ailments, but each one of them has to be treated differently. You will not give an aspirin for cancer and for headache, right? So why should you use the same light dose for these different diseases?
I see. That's fantastic. Thank you for answering that. And, I know our audience is going to be anxious to take a look at your content, your slides again. Thank you for sharing your QR code. And to our audience, I'll see if I can get that QR code from Dr. Arany. Dr. Arany, we sent a follow-up email to the audience, which I'll get into here in a second. Maybe good for us to include that in our follow-up so everyone does have an opportunity to get your slides so they can absorb it a little bit more. But with that, you can also go to education.biolace.com. And I'll show the audience real quick where you can find that website. If you just go to biolace.com, you'll see education there in the main menu. You'll see resources there in the main menu. So it's hard to miss. Once you go to our education website, we are recording this. And we will do a nice editing process, make it look pretty, put it on our webinars on demand library. So if you want to watch this again, just give our team about a day and we will get that posted on our education.biolace.com website for you to watch again. Now, when you go to this website, I saw one question on there about water lathes, and then a couple of questions on there about the EPIC. The water lathe is a erbium chromium YSGG all tissue laser. The EPIC is a diode soft tissue laser wavelength. When you go to the education website, you'll see that there's two different academies. One is the Water Lathe Academy. The other is the EPIC Diode Academy. Great content in both areas of the education website, depending on what you're looking for. If you want to go to the EPIC Diode Academy, you'll see all sorts of online courses, videos, webinars you can watch, content you can download. So I would encourage our audience to go there. Like I mentioned, we have upcoming webinars on demand that are recorded on there, podcasts, all sorts of virtual content that you can take a look at if this intrigues you more. Now, as we wrap up, our next webinar is going to be here in a couple of weeks. on Thursday, September 19th, 5 to 6 p.m. Pacific time. The Prophy to Perio Conversion, Strategies for Patient and Practice Success, should be a great lecture by Tiffany Wubin, so please join us for that. And then you do get a CEU for joining us this evening, so you must be officially registered to get tracked for attendance. Now, the most important part I want the audience to know is, like I mentioned earlier, you get an email within the next day or so from our team. That email is going to have a survey in it. You need to open the email, take the survey, and after you take that survey, you'll get your CE certificate for joining us this evening. That's the email that I'll see if I can include the QR code in to help get Dr. Arany's slides again. So be on the lookout for that. If you don't see it in the next day or so, check your spam folder. I promise it'll be there, and that will be how you can get your CEU for joining us. Again, one more time, biolays.com/webinars is where you'll find this content here in the next day or so after we get it up there. If you have any specific questions for us at BioLays Education, you can reach out via email to education@biolays.com. Even if it's for Dr. Arany and you need his contact information, you can reach out to us and we'll help you contact Dr. Arany. So with that, Dr. Arany, again, fantastic content. Great job. We really enjoyed it and appreciate all your effort to present this great information to our audience. And to our audience, thank you for joining us.